Welcome into Health Matters on CNA938. I'm Daniel Martin. Lung nodules, could they be cancerous? What causes these masses of tissue to form in the lung? And are treatments invasive or non-invasive? You know, recently in Singapore, we saw the first robotic surgery to remove the lung nodules and an abdominal hernia along the way as well. It was performed by Dr Aneez Ahmed, who's medical director and senior consultant thoracic surgeon for the International Center for Thoracic Surgery. I've invited him onto the show today on Health Matters. Dr. Ahmed, welcome to the program. Now, before we talk about the joint lung abdominal hernia robotic surgery that you recently performed, I want to look into the issue of lung nodules. What is this problem and how common is it?
Hi, Daniel. First of all, thank you for having me. Yes, lung nodules are not that uncommon, to put it. So there's a definition where you define nodules as things which are lesser than 2 centimeters in size, and anything bigger than that, you call it a lung mass. Usually, these happen as a scar of our lungs' defense mechanisms to the environmental influences, the smoke, and the things which we live in the present-day world.
And here's the thing, it can happen for both smoking and non-smoking individuals, can't it? So what causes it? Because every time we talk about lung health or lung issues, you know, that group of individuals, the smoker, tends to be highlighted a lot. What leads to the formation of these nodules in the lung?
It is a long-winded question to answer, but let me put this short. Okay, smokers, yes, they have increased risk of developing lung cancer, and these things start as a lung nodule, which I said, as they are small in size. But it doesn't mean that only they have it. It can happen in non-smoking individuals as well. And why does it happen in non-smoking individuals is still a matter of investigation and trials which is going on. Just to highlight, because the public, even I think people should be aware that can happen in non-smoking females have started to show an increasing trend towards having these kind of nodules and cancers.
So when you find one, when one is discovered, what happens next?
First, you will get what is called a CT scan of your chest. And then this is to further delineate how the nodule looks like. And then we have certain kinds of criteria to define them. So depending on the size, shape, and appearance as to how they look like, we have our own needles of suspicion, which can range from benign, meaning not cancerous, to cancerous.
And I'm curious, actually, going back one step, how would you even pick up a nodule in the first place, sir?
Very good question. So we don't have what we call a definitive screening program in Singapore. But it has been practiced in countries like Japan and Korea. And now recently it's also advised with the American Society to screen certain what we call high-risk individuals, gentlemen who smoke and everything. But that goes out of the window in this part of Asia, as I said, because we have increasing trend towards non-smoking individuals. So usually they tend to get picked up when they go for screening for some other things. You know, general health screening, they screen you and these nodules can be picked up. So we call it incidental nodules.
Got it. Okay, so if you've hopefully picked it up at an early stage, what can be done about it? You've recently carried out a joint lung abdominal hernia robotic surgery. That was the first in Singapore. Is this a good option, robotic surgery?
Yeah, to qualify myself, I am a practicing robotic surgeon. So yes, it is not the first time we have done 2 organs, meaning combining chest surgery with the abdominal surgery. But this particular lady had a lung nodule and she also had something called a ventral hernia. So my partner who does abdominal robotic surgery, Dr. Rao, and myself did this operation together. And the advantage being, as we said, it is small cuts and patient goes home, recovers faster from surgery, and she can go home earlier.
How does this differ from what's traditionally done to remove the nodules?
Very good question. So traditional, you would probably require what we call an open surgery, which is called a thoracotomy by definition. The recovery time is longer. People need to stay in the hospital longer, invites complications longer. And then we evolved into doing this through what we call keyhole surgery, which is called the video-assisted thoracoscopic surgery, which I do too. But the difference is that that's a 2D platform. So you look at a screen and you operate. Okay, so it is a 2D platform. The robotic surgery is actually a 3D platform, so you can actually sit and look into the patient's chest or cavity, and you will have 3 arms instead of 2. So you're evolving into yourself into a better operating person.
To do both of those organs at the same time, does that mean, like you say, you worked with your partner on this? Are you all performing it literally at the same time, or is it one after the other?
It is one after the other.
My goodness.
Yeah, that's right.
It sounds so complicated, but of course there are benefits here of having this kind of minimally invasive approach. What are the main ones that you think?
Okay, with the robotic platform, I think, as I said, 1 is 3D. 2, you never have a tremor. The platform removes everything. 3, my wrist can move 570 degrees. God has only given me 360, so I have hyper motion with this. The clarity is amazing, so that the errors which you can commit with this is much less. And then I do sit and operate, so I don't get tired. So, yeah, that's true. And the problem as we grow older for surgeons is we lose our tactile benefit, nerves of steel. The robotic platform kind of neutralizes that. It keeps my experience, but takes away my physical limitations.
For those of you that have not seen it, it might look like you're sitting you're not even standing over the patient, you're sitting at a control terminal, which is just a little ways off from the patient, correct?
Absolutely. I'll be sitting on a console probably about 5 to 7 feet away from the patient, and I will be operating, but I will be operating it. It is called robotic assisted surgery. So still I do the surgery. Yes,
don't worry. It's not that you're programming it in and it's doing it on its own, not like that at all.
It will come in the future. Then I will not have a job, then I'll get to you, man.
That's when you'll be speaking to an AI host of a radio station as well. Actually, speaking of, do you see the trend moving more towards robotic surgery? Do you have to meet criteria, to be a patient that can undertake this kind of surgery? Will it still be very niche in future, do you think?
I think, yes, because it's not going to be niche. I think now, so far, one company had a monopoly. Now you have multiple companies coming in with their own robotic platforms. So the democratization part of robotic surgery is on the way. And I think once we democratize the whole thing, then the prices will drop down even further. And the economic compulsion of using something expensive is gone. And then more and more surgeons are being trained now on this robotic platform. They will definitely embrace it further. It gives you greater benefits for them as well.
And huge utility options as well and benefits. Dr. Ahmed, thank you so much for speaking to us today. Dr. Aneez Ahmed joining me, Medical Director and Senior Consultant Thoracic Surgeon based at the International Center for Thoracic Surgery. I'm Daniel Martin for Health Matters.